Welcome, everyone. And as he mentioned, we're talking about the governing board and contracts because they're so closely tied together with the functioning of any hospital. Now, I'm not just going to cover the conditions of participation from Centers for Medicare and Medicaid. I'm also going to cover some of the other accrediting organizations, for example, DNV and Joint Commission, the Joint Commission, my contact information. So why are we here? That's so you don't get a statement of deficiency should CMS show up and do a survey and then cite you for what's not present. How do you keep up with the changes? Definitely subscribe to the Federal Register. CMS has been working on these conditions of participation since the 60s. Now, not everything is a facility. You will see on here Q, Appendix Q, that's determining immediate jeopardy. So what about those memos that I talked about where CMS sends out the notice to their surveyors? But these go by years. They usually are updated as things come along. I want to talk about the hospital improvement rule because that does affect some of what we're going to talk about today. And this was back in 2019. But what I'm talking about today is primarily with your hospitals, critical and acute. Now, it doesn't just say it's a healthy patient. They really want you looking at your patient. And the reason they did it was because the data was showing that almost 29 million ambulatory surgeries occur after the patient is registered, but prior to the surgery or procedure starting. You still need to document any pre-existing conditions and appropriate test results. So there are two sections that specifically address the board's responsibility. So again, you can have a system-wide QAPI with the exception of if you are a critical access hospital, and then you cannot. Systems and the patient population. The board must make sure that there's something in place. So those are the big changes and how they affected the board in particular with that hospital improvement rule. And this is what CMS comes back and puts into their database once they've come back from a survey. And the way you would access it is go down to the bottom of this slide, number 27, there's but don't let that freak you out because you can filter, sort, really pinpoint on what you want to find. Once you get in there, go to your state, then you can really pull down where you want to go. I pulled up one of my former hospitals, and I'm happy to say they're doing very, very well. As for board and what we're covering today, so let's go ahead and start with the actual board section. So first off, you have to have an effective governing body. Now that right there is a whole mouthful. Effective governing body. By the way, there is no survey of hospital systems. They must have their own CNO. Each hospital must have their own CNO. You cannot have one whole nursing service department between two or more hospitals just because you're in the same system. The board must make sure the staff requirements are met. So here's tax 45, and that is pretty much the overlap with the medical staff and the board. The board has the flexibility to determine also who else can be appointed along with the state law. That's what a blue box recommendation would look like. It's not cited, just gives you good information on it. Again, others may be eligible for privileges. Of course, that's based on state law and what the medical staff bylaws say. What about appointment by the board? The board appoints, and they want to make sure there is some involvement of the board in the appointment of the medical staff. So to do that, the board has to make sure that the medical staff has bylaws off which to operate. The board must make sure that medical staff is accountable to them for the quality of care that is given. Given to patients must be under the care of a practitioner who has privileges. The board ensures that the criteria for selection is based upon multiple things. The board must make sure that under no circumstances, let's step over to telemedicine. This got its own little tag number. In that conversation, that consultation, it must include matters that relate to the quality of care that's provided. Because what you need to cover is not only the scope and complexity of what you're doing, the governing board must make sure that the discussion is on quality of care issues. I want to point out just one thing as a side note. As far as contracted services, the board's responsible. If you have an emergency department, this is what you have to comply with. Well, I want to switch over to critical access hospitals because again, a little bit different animal when we're talking. Now, the interpretive guidelines in line with the medical staff, the surveyor will verify there is a board or some written documentation that identifies that individual. Critical access hospital, and that talks about disclosure of changes. Well, let's switch over to the contract sections. Why did they get cited under contracts? They didn't monitor contracted services that were coming in. So here are some of the specific citations. laundry services, neuromonitoring, security officers. That was a big one. I want to point out one thing that you can use as a self-assessment tool that might help with some of this. And they're the worksheets. CMS has 3 of them. During the review session, what the surveyor is going to do is, first off, they want to see any contracted patient care services agreements. When they talk about being delivered in a safe and effective manner, so keep a list of all your contracted services. I would urge you to keep them in one spot. Now, this is only a draft. This is just strictly draft, and it talks about co-locations. You must have an agreement with one or more of the providers that do participate in Medicare and provide services to your patients. Think telemedicine. The governing body acts according to the QAPI program. Same with an acute. What about lab and other diagnostic services? Of course, you have to have policy and procedures for any specialized lab services that you can't do or don't do. Another contracted service can be your food service, your nutrition. I mentioned I would talk about some of the other accrediting agencies and Joint Commission. That's because they do have contract standards for it. There's 4 sections of leadership standards that there's something to complete right in behind them. So you want to have a system to manage those contracts. So for contracts under Joint Commission, this is what they've asked about. How do you decide where to get your drugs listed on your formulary? It helps you know and identify the scope and nature of what your contracted services are, because the surveyor is going to ask your leaders. You also have to make sure that the board is monitoring. DNV SR4 talks about telemedicine and an entity. Again, this is an entity. Does a contract require 30-day advance notice of cancellation? Is there a way that you can flag termination or renewal dates? Do you specify the minimum limits of liability that the contracting party should carry? So here's just some additional guidelines for you. And this is how one hospital's process was. So I want to wrap this up with a quick discussion, then we'll open it up for any questions that you might have. Thanks everybody for participating in today's conversation. Again, today is August 13, 2021, and we were talking about governing board and the contracts. Just be aware again, I want to reiterate that CMS and Joint Commission are really evaluating the contract section with their surveys to make sure that the board has accounted for what the hospital needs, whether it's resources in way of persons, that they're monitoring these contracts and they're keeping track of them. So with that, thank you again for attending, and I will turn it back to our moderator to close us out.
Thank you, ma'am. Thank you, participants. With this, we conclude the session for today. Thank you so much for joining today's webinar. Have a good day.